The paediatric ECG is something that can baffle so many of us. Commonly, it leaves us feeling confused, uncertain, and also with a tendency to call for specialist input more than we need to. If you've got a simple plan that you can follow, you can go through it logically. So here's how to do it. Before you start, check that everything's working okay. Check that you are using the right scale on the ECG. Standard ECG should be set at 10 millimeters per millivolt on the y-axis and 25 millimeters per second on the x-axis. Every calculation that we're about to discuss depends on it being at this standardized level. So it's really important to make sure that this is right before you start interpreting the ECG. With the standardized values, one small box is 0.04 seconds. First up, we're calculating the rate. The rate is very easy to calculate. What you want to do is measure the number of large boxes between one R wave and another R wave. Then you do 300 divided by that number, and that's your rate. Next, we're going to look at the rhythm, and what we want to know is this normal sinus rhythm? That's going to depend on two things, on the rate and then mainly on the P waves. So the rate needs to be a normal rate for age. Then we go on to look at the P wave. So the actual P wave is made up of two waves, which is right atrial depolarization and left atrial depolarization. But because of the time that these happen in, they actually merge together and they form one P wave. What we want to know is that there's a normal P wave axis. So that means you want to see upright P waves in leads 2, 3, and AVF. And the axis of the wave gives us information about where the right atria is situated. Next, we want to look at the P wave morphology. So is it the right shape? Because what you want to know is that the current moves from the sinoatrial node away from it over a normal time period. If the P wave looks broad and it contains a notch, so it takes up a longer amount of time over the x-axis, that suggests this left atrial enlargement. If it's peaked or spiky, then it means the voltage is high, and that suggests a right atrial enlargement. We need to make sure there is a P wave before every QRS complex, and we need to check that there is a normal PR interval. The PR interval is a short lag as the electrical activity reaches the atrioventricular node. The P wave amplitude should be less than 3 millimeters. In less than 2-year-olds, it's going to be 0.08 to 0.16. In 2 to 15-year-olds, it's going to be 0.08 to 0.2. And in over 15-year-olds, it's going to be 0.12 to 0.2. Tall P waves are called P pulmonale and suggest right atrial dilatation, and bifid and wide P waves suggest P mitrale, which is left atrial dilatation. So what we've seen is that most of the criteria here for normal sinus rhythm are about the P wave, but remember the rate is in there too. So if you've got normal P wave elements that we've talked about, you've got a rate that's very fast, then what you've got there is sinus tachycardia. Next, we're going to look at the QRS axis, and what that means is the direction where the bulk of the current is heading. Outside early infancy, it should be heading towards the muscle bulk of the left ventricle. We calculate the axis by looking at leads 1 and AVF, but actually you could look at any two perpendicular leads and you're looking at the net deflection. You plot this then along lead 1, so either in the positive direction or the negative direction depending on the deflection. And then you do a similar line reflecting the overall deflection in AVF. Then you draw a further line which goes from the base of the first line to the tip of the line drawn from the angle of AVF, and that's the cardiac axis. In normal 1 to 8-year-olds, you're going to have an axis of 0 to 90, and you might also see mild left axis deviation up to -30. Normal puberty to adulthood, you're going to have right axis deviation, and in normal less than 1-year-olds you're going to have an axis of 90 to 180 degrees. Next, we need to look at the ST phase. This is an isoelectric segment, which is what happens just before the heart resets itself. So you shouldn't be seeing ST elevation here, you should be seeing an isoelectric ST segment. Next up is the QTC. So the machine is going to give you a automatically calculated reading here, but you are definitely best to calculate it yourself every time. This is because you're going to get better accuracy as to where the T wave actually ends if you calculate it yourself. The QTC is a corrected calculation of the QT interval that takes into account the heart rate. So to calculate the QTC, you take the QT interval and you divide it by the square root of the preceding R interval. In 0 to 6 month old babies, you're going to have a variable QTC. Anything up to 0.46 seconds is okay. In over 6 months, it should be less than 0.45 seconds. We've looked at the QRS axis, but now we're going to look at the QRS complex itself, and what that represents is ventricular depolarization. The duration of the QRS is going to increase with age, and it also increases with bradycardia. The maximum duration is usually 0.12 seconds in childhood. Partial bundle branch block, i.e. without QRS prolongation, that's a normal variant finding. In bundle branch block, you're looking for the pattern that you've probably heard about, which is William or Marrow. And then you want to look at the height of the complexes across the chest leads. If you've got tall complexes in V1 to 3, then you're looking at right ventricular hypertrophy. If you've got tall complexes in V4 to V6, then that suggests left ventricular hypertrophy. And finally, we're going to look at the T wave. So here what we're looking at is ventricular repolarization. After birth, you get physiological inversion of the T waves in leads V1 to V3. As the child gets older, these then turn upright in reverse order. And so usually by the age of 8-ish, they'll be upright, but it is quite common to get persistent inversion of V1, which is a normal variant. What you're looking at also is the morphology of the T waves. So you want to check if they're very tall, if they're very broad, or if they're biffid, or they're very short and flat. If a patient's bradycardic, you can get a U wave, and that's normal. They should be in the same orientation as the T wave. So we've gone through a systematic approach to looking at every single pediatric ECG, along with some specific things that you should be focusing on if you know the particular thing you're worried about. If you like this video, you might enjoy checking out our Bubble Up YouTube channel, which is our new channel with non-clinical videos on it.